Male, 80 years old. In January 2015, he presented persistent diarrhea with weight loss and no abdominal pain. A CT scan showed a pancreatic mass in the body with dilated MPD in the tail and retentional pancreatic cyst of a size of 2 centimeters. Two previous series of EUS-FNA were negative with 22 and 25 gauge needle. So it's a picture of the scanner, and it's decided to realize and to complete the investigation with EUS and FNB. We can join Dr. Petran and Dr. Santo in room 1.
So I'm looking for this area. Moving from the hepatic hilum, this is the portal vein here. Going towards the confluence, we have the body of the pancreas here. And we can recognize the pancreatic duct of the isthmus. If we try to follow in the pancreatic duct towards the body of the pancreas, you can see that we can't follow it. So in this area is completely closed, like a stenosis, and then when I move towards the tail of the pancreas, the duct was really a little bit dilated. Okay, so we are looking for the tail of the pancreas. Just here in this area you can see the dilation of the pancreatic duct.
Maria, you said dilated. What is the size, the threshold of pancreatic duct to be dilated?
I can check immediately. Just here in this point we have about...
If you mean generally, Christoph, then we have this simple rule of 3 to 1. 3 in the head, 2 in the body, 1 in the tail. This is the normal.
And here we have 6 millimeters of dilation. So there is a dilation of the pancreatic duct in the tail with some branch ducts that are visible. And now I'm going towards the body again. So this is the area completely dishomogeneous, and this is the pancreatic duct again in the neck of the pancreas. And we can check here the caliber. It's normal.
Oh, actually, we are looking quite difficult to define, to delineate this this lesion.
Yeah.
Maybe with the elastography you'll have a clearer picture, because we can see a more better defined.
Yeah, the lesion is not a clear focal lesion. The only thing that we can see is that the pancreatic duct is completely
closed.
It's
a cutoff.
There.
We have a cutoff of the pancreatic duct, which, as we mentioned before, it's a indirect sign for a lesion. But it's not so easy to see a definite lesion.
Yeah. So we can check with Sonoview?
Yes. I think that could help as well. If we can find an area which...
So you are scanning right now from which position? And
so the scope
we have seen only so far some parts of the pancreas.
So now the scope is just past the cardiac in the fundus of the stomach, where we can see the body and the tail. So moving from the left liver lobe, we can check then the portal vein. Here we are. And the confluence. So we have the splenic vein and the superior mesenteric vein here. And probably there is always, you can see here some many calcification of the splenic artery.
So the area...
Have you had the chance to examine the head of the pancreas from the duodenum beforehand?
Yeah, we
Or
try, but
it's difficult to pass.
no, it was not difficult. We tried, but then now we are ready with the Sonoview.
Just to point out for Maria that it has flipped the image back because the Sonoview setting is the opposite to your normal preferred setting. So just in case you hadn't noticed that
Yeah, that's right.
it's actually...
Mara, you're working,
Yeah.
but she's very skilled. She
Thank
knows
you.
both ways, so there's no problem for her.
You're ambidextrous.
Yeah.
Okay.
No, okay.
You can see there are some vessels inside, but it's hypoechoic. I think it's not announced.
No, there is some enhancement in the periphery, but the center is actually not getting anything. So,
I agree.
So I think we
Okay.
should go for that. So we go back.
Yes, thank you.
Okay, so we flip back.
I think that we are going to puncture this
Yes,
area.
we should, because this is clearly a suspect area. You have a duct sign there. There is a difference between calibers.
Yeah.
And hypoechoic, although not very well defined, and we should go there close to the changes. To the, in my experience, usually when you go in this area, where actually the change is taking place,
Yeah.
then there is your money.
Okay, we try with the 25 gauge.
Yes,
what do you
I
think?
think a 25 gauge needle here is very good because we just need a yes or no answer for a carcinoma.
So I always love the pretest probability. A ductal adenocarcinoma, not seeing a mass lesion using B mode, to my understanding and experience, is almost never occurring. So what kind of pathology do you suspect by biopsying that area? Are you thinking of autoimmune pancreatitis, or what kind of pathology do you expect?
You're right, Christophe, that usually adenocarcinoma it has a different, will have a different echogenicity, but sometimes you see isoechoic areas as well, and especially if there were not change in the caliber of the duct in this area, then the suspicion, I think you're right, adenocarcinoma would be less likely, but when there's a definite change, when you see a dilated duct, a normal duct, then a dilated duct, and in between them, somehow different echogenicity area, I think it's still suspect for adenocarcinoma. At least you have to rule that out. I think this is my opinion.
I agree with you. And moreover, I have to say that the behavior of the contrast agent in autoimmune pancreatitis is completely different. So it's an hyper-enhancing pattern. And the pancreatic duct usually is not in this way, but you see a thickening of the pancreatic duct wall. So I agree with you, there is no focal lesion, but we have only an alteration of the caliber of the duct.
Which is a strong and indirect indication of lesion there.
Okay.
But just for a beginner like me, where right now is a cauda pancreatis and where is the head? Is the cauda to the left, the tail, or to the right?
Okay. We have, sorry.
Mara, you want
We
to?
have here we have the body of the pancreas here, the head of the pancreas in this area, okay, and the tail of the pancreas on your right. So I'm going to puncture the body of the pancreas. I would like to direct the needle just in the best position where there is the stenosis of the duct. Okay. Capillary.
So you use the slow pull technique or the no
Don't worry,
stylet?
doesn't matter, doesn't matter.
Or
We
use the
usually we usually use the capillary technique. We removed slowly the stylet. Please.
You want suction or
Yeah.
you want suction?
Now we try with suction. Okay. Thank you. We can go to check for the head of the pancreas. If we have some time. We put in formalin or? Yeah, cytolite.
We have a question.
Hello.
Yeah?
Yes, we hear.
Can I ask a question, please?
Yeah, please.
Hi. My name's Stephen Silcox. I'm from Australia. I'm just interested to see that in all the cases so far, we haven't seen an in-room cytologist, and you're even then contemplating putting a sample into formalin. I guess that's a two-pronged question. Why do you not use in-room cytology? And secondly, if you were, why would you contemplate putting a sample into formalin directly?
So the question is why I use this fine needle?
No. The question was about the pathologist in the room.
I'm sorry, I didn't get.
Yeah, I mean, there's many studies that have demonstrated superior outcomes from in-room cytology, so I'm interested to see why it's not being
You are absolutely right. I think if you have the luxury, the possibility to have a pathologist in the room, that's okay. But I think most of the places, except of the bigger centers, they don't have the pathologist in the room. So this is the situation at this moment here in the. Yes.
Yeah.
So we actually go for the routine with no pathologist in the room.
Yes, please here. The
Mark,
pathologist, but there is no microscope.
Don't spoil my answer, please.
So the other part of the question was the concept of putting a sample directly into formalin, as distinct from
Actually, in my practice, that's what I'm doing. I'm putting the specimen into formalin, and if there are some leftovers, I go for cytology. I don't know, Mara, what you are doing in your hospital.
We have the on-site technician in room with us, so.
So you see, she's fortunate.
Yeah,
Normally, she has the technician in the room.
So I fully agree with you. I performed the second passage because the first one there was no
Okay, that's
material.
good. You were very close.
With capillary technique, please, very slow.
Yes.
Have another question?
Yes.
Actually, I don't agree with the steps you have, sir, because I believe that we have to complete the examination fully of the pancreas. We have to assess the head, the body, and tail, and afterwards we have to decide which area we have to have biopsy. So I prefer to complete the examination and examining the head quite efficiently, and then I start to decide what area I have to take biopsy. Thank you.
You are absolutely right. Normally, in the normal life, what we are doing before attempting any biopsy, we should examine the pancreas, the whole pancreas, and then decide and then go for the biopsy. You're absolutely right. In this case, we had a failed previous biopsy. The pancreas was examined. So we know that this is the lesion, the most suspect lesion, and the purpose was to repeat the biopsy. But you're absolutely right. We shouldn't do anything before examining the whole pancreas. But it's a different story here.
Yeah. So how was the second passage? There is
Oh,
nothing
the
inside.
second. Oh, you can have a look at the second one. The second one is
Not bad.
a good, not bad at all. A very good specimen. So, would you go for another one, or it's enough?
It's enough. Mark?
Mark, we have quite a good specimen in this one. You think you should go for another one, or this is enough?
There are calcifications in the image to the left, or is that an artifact? What kind of calcifications can we recognize here?
Yeah, there are many calcification along the splenic artery. So you have some problems with this.
So we had a typical response from the pathologist, the more the better.
Another
So
one,
we will,
of course.
we will have another pass, but she's right, because usually when we do not have a pathologist in the room, the practice is to have at least 3, 4, some people even do even more. I see Anand is not agreeing to what I'm saying, but at least in the literature, that's what they say, that at least you have 3 passes or more than 3 passes to maximize your chance to get tissue. But in this case, we had a previous failed biopsy, so I think we should do at least one more.
Yeah, you're
or
right.
Maybe another one.
From the European guideline, when the pathologist is not in room and you have the suspicion of a pancreatic cancer, they suggest 5 to 7 passages.
Yes, I know.
So right.
Expanding, I think the number can be less.
But for me, at least 3 times, I think it's a good number.
Okay.
Okay, I think it's perfect.
Yeah, please.
So now we will try with the slow pull technique, meaning that Stefan will slowly remove the stylet and Mara will move to and fro.
Is there a possibility of chronic pancreatitis, because there are a lot of hyperechoic foci? Can it be chronic pancreatitis with the phlegmon in the body region? Is there a possibility of that?
I don't think so, because there are many calcifications along the vessels. So
The calcification. If we looked at the parenchyma, the majority of the parenchyma looks normal, so it doesn't look like chronic pancreatitis.
This is probably the most difficult case of the day, and I'm not very fair to give this to a nice and very nice lady like you.